We move ahead to the last speaker of this segment, and that is Dr. Tarun Dave. He is a senior consultant interventional cardiologist from Ahmedabad to speak for the next 11 minutes on Rosuvastatin in coronary artery disease. Is it the first choice? Dr. Dave, if you're ready, that's the timer. The next 11 minutes are all yours.
I sincerely thank organizer for giving me this opportunity. And today we hear a lot about a progress made by India and what is being there for future for India. But unfortunately, we have made a lot of progress in two chronic diseases in India. Next. Can you go to the next? Or should I do it? Okay. You see, we are at the threshold of seeing an epidemic of diabetes and coronary artery disease. And as per this projection, the mortality and morbidity, and of course the financial resources which will be utilized to treat this disease are going to be higher and higher. And there is a reason why the Indians are at higher risk. We feel that the Indians get this disease at a very younger age. The previous speaker has rightly said the women are also now being affected more frequently, even among the premenopausal age. There is a more severe disease, more diffuse disease, so even our revascularization procedures, which are good for a discrete diseases, are not so suitable for the type of the diseases which we see. And that's why we need to have a sort of a meeting like this, where other than the simple revascularization strategies will be useful to reduce the burden of this problem. And ICMR has projected that there is a very high incidence of hyperlipidemia. They carried out a study from the 4 states, and nearly 7.7% of the adult population had 3 lipid abnormality, which constitutes them, I would say, the atherogenic lipid profile. High triglycerides, low HDL, and elevated LDL. And in this, as already has been said, the small dense particles of LDL and HDL contribute significantly along with the elevated triglycerides for Indians to get these diseases in a more devastating manner and also presenting at an earlier age. This slide has already been taken up, but that shows that how the low LDL, the small dense LDL particles as well as the HDL particles contributes to this problem. Well, LDL constitutes only 1/3 of the problem which we see in the clinical setting. But non-HDLC, or what is being said as the residual risk when you look at the lipid profile, is also equally important and need to be targeted by the therapy for the hyperlipidemia. And in this regard, there is a great role of statin in days to come, and already we are seeing the benefit of intensive statin therapy in this regard. You see, there is a linear relationship that if you bring down the LDL, then obviously the long-term mortality related to the coronary artery disease also can be brought down. Roughly 30 milligram deciliter reduction in the LDL will correspond to nearly the same amount of risk reduction for CHD patients. And that's why there is a change or shift in the emphasis from the various international groups, that initially there was an emphasis for a low to moderate dose of statin therapy. From there, we have come to a recommendation to the high intensity statin therapy, namely either 80 milligram of atorvastatin or 40 milligram of rosuvastatin for those individuals who have demonstrated the evidence of the atherosclerotic disease in the body. And sometimes to treat the non-HDL component or the residual risk, you need to have a combination therapy over and above the statin to achieve the goals. And this shift is because we have found that the combination of the other drugs or the other drugs which are used to reduce the lipids like say fibrates or acetamide or nicotines, nicotinic acids have not shown any substantial benefit in reducing the risk. So there is a great emphasis for the statin, and high intensity statin is must for all those individuals who have shown the evidence of the atherosclerosis in the body. So irrespective of the lipid profile, they need to be on the high intensity therapy. And the various trials have shown that if you bring it down at least below 100, then the risk is significantly reduced. But how low it should be is a question of debate. This is the recent recommendation that anybody who has a clinical atherosclerosis should have high intensity statin therapy, and those who have the LDL value which is more than 70 up to 189 in presence of diabetes also need a moderate to high intensity statin therapy. Well, there is also a role of statins for the secondary prevention, particularly to bring down the LDL as low as 70. The patients who are coming with the ACS, irrespective of their lipid profile, need high intensity statin therapy, and those who are undergoing the intervention also need a high intensity statin therapy to reduce the peri-procedural myocardial necrosis and also to reduce the contrast related injuries to the kidney. We have a number of trials for primary prevention and the secondary prevention, and also in the setting of acute coronary syndrome where high dose statin therapy had shown a significant benefit. I will not go into the detail because of the constraint of time, but most important, the conclusion in various trials is that if you bring down the LDL below 70, you get the maximum benefit, whether it is a primary prevention or whether it is a secondary prevention. Now a word about which statin. Of course, most of the trials have shown the benefits with either Rosuvastatin or Atorvastatin, but we are aware that the Rosuvastatin is, in terms of the milligram, is more efficacious. It is shown in the STELLAR trial that 20 milligram of the Rosuvastatin will produce probably an equal amount of the reduction in the LDL which is produced by Atorvastatin. So as far as the effect on the LDL is concerned, probably the Rosuvastatin is highly effective. And the atherosclerotic potential of the plaque, it also depends upon the components of the morphology of the plaque. And the statins have shown that the volume of the plaque can also be substantially reduced by use of the high dose statin therapy. And that has opened up a new era of evaluating the plaque regression with the Rosuvastatin therapy. Thus, some of the trials like say Asteroids, Cosmos, Saturn have shown a significant reduction in atherosclerotic volume, reduction in the carotid intima media thickness, reduction in the lipid content of the plaque, and that is how overall reduction in the recurrence of the coronary events rate have been demonstrated. This is a trial like say Asteroid had shown a significant improvement in the mean atheroma volume in the patients who were treated with the Rosuvastatin for over a period of 2 years. And the other trial has also shown that there is not only a reduction in the plaque volume, but the net gain in the lumen size at the site of the lesion was also demonstrated in tune of about 7.5%. And that's why the vessel volume also improved, which improving the overall long-term event rate in these type of patients, consistent with the theory of statin-induced atheroma regression. The this is another trial like the Statin trial have shown that the fraction of the patients also in fact shows a definite regression with both atorvastatin as well as rosuvastatin, but probably it is little more with the rosuvastatin in dose-to-dose comparison. The IVUS studies have also confirmed this observation that there is a median change in the total atheroma volume when you are using a powerful drug like say rosuvastatin. Carotid intima media thickness, which is one of the parameter which can be easily evaluated by the ultrasound examination, has also shown that the rosuvastatin intense therapy will produce a significant reduction in this carotid intima media thickness, and this is more powerful when you have more number of risk factors. So more number of risk factors and you are giving the rosuvastatin, probably it is much more helpful. The rosuvastatin has also shown with these two studies that whether it is a primary prevention where the disease has not manifested, but you have an evidence of the non-invasive test like say increase intima media thickness or high calcium score, and you start with them these patients the rosuvastatin therapy, or the patients who already have demonstrated the disease and you start the intense therapy with rosuvastatin, probably it is helpful in regression in both primary as well as the secondary prevention. The other study has shown that what is being talked about in the acute coronary syndrome is the vulnerable plaque. And when you give the rosuvastatin to these patients, the lipid-rich necrotic cores are also significantly reduced by the rosuvastatin therapy. I will go to some concluding slides. The another advantage of the rosuvastatin is that the loading dose reduces when the patient is being taken off for the procedure, reduces the incidence of the peri-procedural myocardial necrosis and reduces the contrast-induced injury to the kidneys. And these are two important advantages of giving a loading dose just before the procedures. It has a more hydrophilicity and more selectivity for the hepatocytes. That's why probably it is more efficacious in bringing down the values of the lipid abnormality. Now it has been demonstrated even smaller dose in Indian population, like say 5 milligram of rosuvastatin or even 2.5 milligram of rosuvastatin has also shown a substantial reduction in the LDL cholesterol. So even the lower dose you can start for an appropriate patients. So to summarize that we have today availability of the statins which should be generously used over and above the lifestyle modification, at least in those patients who have demonstrated the evidence of the atherosclerosis anywhere in the body. Thank you for your attention.
Do we have
Thank you very much, Dr. Dave. Any questions?
Sir, as has been amply demonstrated that we Asians have our own genetic predisposition for CAD, and we have a different epigenetic atmosphere also, and we have a atherogenic dyslipidemia which doesn't match with the Western literature, and whatever has been recommended is based on the RCTs which have been done in the Western countries. So is it really necessary for us to implement those in our setting, because it lacks the evidence from our countries? There have been no, not to my knowledge, or maybe you are much more knowledgeable about the RCTs which have been carried out in India. So we must look into the from Indian perspective point of view, because there are other elements like hypertriglyceridemia, low HDL, and already obesity, metabolic syndrome, and we have so much of incidence of diabetes. Diabetes itself has got a different diabetic dyslipidemia. So I think we need to focus more on these recommendations. Like in a patient who doesn't have any other risk factor, and it has been recommended that anybody with LDL of 180 and above should be started on a very high dose of rosuvastatin or statins.
No, I totally
So,
agree.
your
that,
comment on this?
Yeah, I totally agree that we need to have an RCT focused on our population. But unfortunately, I also don't recall that there is such a one can match these kind of RCTs from only Indian population. So in absence of that, what to do? The dilemma is that. You see, some work has been done by some of the workers like say Inas, and they have shown, but we do not have such a long-term data with our work. And in absence of that, I don't think we can sit silently. I should encourage to have this kind of data. But till then, we need to give and treat the patients. That's what I told. That even 2.5 milligram is effective. No, I agree. If low dose can achieve it, unfortunately, the last recommendation, lipid.
Okay.
Yeah, but where is the data? Yeah, that data is not generated. So till then, we have to follow the data, whatever is available. I totally agree that we need to have a data purely from our population. Right, your comment, madam?
I'm just curious now what your thoughts are on the role of rosuvastatin with the emergence of the PCSK9 group of inhibitors, and how you see, with their significant improvement in cardiovascular events, as well as the very dramatic lowering of LDL. What do you see? How do you see that fit in?
If I understand your question correctly, the effect on our patients' LDL values, but that's what.
No, effect on our practice patterns in the coming years with the paradigm shift of, ACC suggested we don't need targets and guidelines, and now
it's still a question of dilemma. But what because this is being discussed for last 2 years once this guideline have come up. But I think there is a change in the practice pattern advocated by the cardiologists and by the other group of drugs, because the cardiologists actually are more involved in India in the interventional procedures. So they want that their patient need not to come back. And that's why they adhere to the guideline with a very high intensity therapy. Whereas that is, I'm not sure whether how much that is being advocated by the primary care physicians across the other parts of the areas. But I feel that the most of the physicians, they liberally use statin once they have an evidence of the atherosclerotic disease.
Thank you.
Whether not to follow, because how long, the other question is, then patients are always demanding that you reduce the cost. Now if you give the high intensity statin, till what time you will give? So today you have an acute coronary syndrome. You give it for 1 year, you give it for 2 years, but then how long will you tell them that you continue with this? When they come up with a LDL value of only 50 in the follow-up after 2 years. So that is also becoming a problem.
Thank you, Dr. Dabe.
Thank
We'd
you.
like to thank Professor Aarti Lalchandani for chairing the proceedings, and the President, Dr.